Hi, everyone, and welcome to our 29th virtual shadowing session. Tonight, we have a wonderful guest speaker, and she's going to be discussing PM&R in sports medicine. This is our fantastic team: myself, Shayon, Taylor, Elena, Rachel, Ani, Miriam, Rohit, and our physician coordinators, Dr. Raymond Fowler, Brandon Morchetti, and Dr. Gilberto Salazar. And as usual, if you have any questions, go ahead and put them in the chat. We'll have a Q&A session in the middle of the presentation. Our upcoming topics: next week, we will be doing burnout in medicine with Dr. Courtney. The following Tuesday will be wilderness medicine with Dr. Reno. After that, in the new year, we will be starting out with a specialty spotlight in OB-GYN with Dr. Dillon. And following that, we have a PA spotlight in infectious disease with 2 PAs. And, okay, sorry, that's at the end. And so the announcement about QuestSpace, I just wanted to let everybody know that QuestSpace is down, as I'm sure most of you know. And we will be extending session 27's assessment, or 28 session, session 28's assessment. We don't know the date or time yet, so just keep watching our Instagram and our website, and we will make sure that you guys get your credit. Okay, so Dr. Swenson, you are welcome to take over.
All right, let me share my screen. Let's see, I'm getting the multiple, oh, there we go. Am I sharing the right screen? Share. Perfect. All right. Can you see that? Can you see my presentation? Okay.
Beautiful. Beautiful.
Perfect. Just wanted to make sure. So first of all, I just want to thank you all for being here. I'm super excited to get a chance to talk to you guys, and thank you to Dr. Fowler, Dr. Salazar, Reagan, the rest of the team. I really appreciate you guys having me. My name is Thea Swenson. I am a second-year resident physician in Physiatry, which is also known as PM&R, or Physical Medicine and Rehabilitation. Oops, let's see. And I just want to give you a quick outline of some of the things that I'm hoping to talk to you about today. I know a lot of you are pre-health, pre-medical students, so I'd like to get a chance to introduce myself and tell you a little bit about where I came from. I kind of took a little bit of a non-traditional path into medicine, so I love sharing how I got here. And then I want to focus on physiatry. We're going to talk about what it is and go over a few case studies to give you an idea of the conditions that we see as physiatrists or PM&R doctors, and some of the things that we do. And then we will talk about how you become a physiatrist, what the training is like, why you should think about becoming one. And then I always like to end with some advice that I have based off of the things that I have learned throughout my career thus far. So a little bit about me. I was born in Los Angeles, California. Both my parents are Vietnamese. I went to college at Stanford, and while I was there, I spent a lot of time trying to figure out what I wanted to do. I didn't really ever think about becoming a doctor. I have a lot of relatives who are physicians, but neither of my parents were doctors, so I never considered it until towards the end of college, after I had tried a lot of different things before deciding to choose medicine. I actually didn't ever think I was competitive enough to go to medical school. So I started thinking about becoming like a dentist or an engineer, something else that I thought was something that I could really specialize in right off the bat. And I realized that while I was looking around at different career paths, what I ended up doing was figuring out what I love doing and trying to pursue those things. So I found a major that sparked my interest, and that was called product design. It's actually a very unique major through the Stanford Design School, if any of you know it. But it's a subset of mechanical engineering with a greater focus on human factors, creativity, aesthetics, and we studied design theory. We worked with various companies. We worked with carrying ideas from concept to working prototypes. And ultimately, when I graduated in 2013, I still wasn't sure what I wanted to do. So I ended up working for various health tech companies in the Bay Area, one of which is Doximity. And if any of you know it, it's kind of like a LinkedIn for physicians. So I worked with them for some time. I did some marketing with them. I also did some research projects at Stanford at the School of Medicine. And during this time, I actually stumbled upon some physiatrists at Stanford. They were teaching a class. It was called Lifestyle Medicine class. It was also a musculoskeletal medicine class. And they took me under their wing, and I started doing some research with them. And after taking their class and getting to know them a little bit more, I became interested in medicine, and specifically in becoming a physiatrist. So I ended up going to medical school 2 years later at the University of Colorado. And currently I'm a second-year resident, as I said, at Vanderbilt in physical medicine and rehabilitation, or physiatry. And you might think, looking back, that I always wanted to be a physiatrist, maybe even before I went to medical school. And if you're thinking that, you might be right. So today I'm hoping to tell you a little bit about physiatry, so that just like my mentors at Stanford, I might inspire some of you to become physiatrists, as well as to choose medicine as a career choice. All right, so what exactly is physiatry? The word comes from the Greek words physikos, which means physical, and atresia, which is the art of healing. It is a broad field, and we specialize in a philosophy as opposed to an organ system. So that's something that makes our specialty very unique, as opposed to other specialties which focus on organ systems like the heart or the lungs or the kidneys. And the diseases that correspond to those systems, we really focus on prevention, restoring function, independence, and maximizing quality of life. So we're considered the medical experts when it comes to maximizing function that has been lost through injury, illness, or other conditions. One of the things that I love most about our specialty is that we work in teams with other healthcare professionals. And I'll go into a little bit about this later. And I also want to back up and say that physiatry is one of the newer subspecialty areas of medicine. Our field actually really began to develop during World War I and through World War II and the polio epidemic. And during these periods, there was an increasing need to take care of injured veterans who are returning from combat, as well as patients who were continuing to live with chronic disabilities and weaknesses after suffering from polio. So we were first recognized as the medical specialty in 1947. So some of the conditions that we treat a broad range of conditions and work with diverse patient populations. And in theory, any patient, I like to think, can benefit from a physiatrist, including everyone from tetraplegics, stroke patients, traumatic brain injury patients, to Olympic athletes. And some of the conditions that we treat in the neurologic system include brain injuries, spinal cord injuries, stroke, multiple sclerosis, and Parkinson's disease. Within the MSK system, we treat patients with amputations, osteoporosis, arthritis, work and auto-related injuries. Pain is another big symptom that we treat, and that pain can come from joints, bones, muscles, ligaments, tendons, bursa, as well as back pain. And we also oversee rehabilitation programs, for example, for patients with primary cardiac and pulmonary problems. And this can include patients who are post-transplant or who recently had a big open heart surgery, end-stage COPD, and other chronic conditions. Some of the diagnostic tests that are within the scope of practice for physiatrists include X-rays, MRIs, and CT scans. Ultrasound is also a very important skill for a physiatrist. Nerve conduction studies and EMGs are another skill that we receive training in during our residency. Nerve conduction studies evaluate the function of motor and sensory nerves, and this helps us distinguish the location of a nervous system lesion. EMGs, or electromyograms, help us distinguish whether weakness is due to muscle or nerve dysfunction. And we use EMGs to diagnose these conditions. The process involves inserting very thin electrodes into the skin and detecting the electrical potential generated by the muscle, which helps us elicit pathology. So I just have a quick video. I think that it's often easier to see what nerve conduction studies and let's see, pause that. EMGs are through a video rather than me try to describe it. So I'm just gonna fast forward, let's see if my internet can handle this. All right, to here, to give you
based on your symptoms. So the length of the test is different for every patient. Usually it takes between 30 to 60 minutes. First, the technologist or doctor may warm your body by wrapping you in a blanket or soaking your hands in water. Warming your body helps them conduct the best study possible. Then there are two parts to the study. First, the nerve conduction study uses small electrical shocks to study your nerves. You need to relax your muscles during this portion of the test. Some patients report that this feels like a series of carpet shocks. Next, the needle EMG uses a small needle to evaluate your muscles. The doctor may ask you to move a certain way while the needle is in the muscle. You may feel some discomfort during this portion of the exam.
All right. Did you guys hear that okay? Hopefully. Okay, perfect. So that gives you a little bit of an idea of some of the diagnostic tests that we do. Some of the treatments that we offer. So physiatrists, we're not surgeons. We do not perform surgery, but we treat conditions non-operatively. And this can come in the form of several modalities. One is injections. So we do peripheral joint injections to both diagnose and treat disorders, which can be done under ultrasound. We also do trigger point injections, and we use that as an adjunct to treat myofascial soft tissue pain. And specialties within PM&R, like interventional spine, for example, use fluoroscopy, and that provides non-surgical pain relief for back pain. We also manage spasticity, which is like stiff or rigid, tight muscles, by using Botox and other injections. And along with that, we also prescribe oral medications and manage baclofen pumps. We also oversee rehabilitation programs, like I'd mentioned earlier. We work in interdisciplinary healthcare teams. So other members of our team include physical therapists, occupational therapists, and speech language pathologists. So physical therapists really help patients improve their movement. Occupational therapists work with patients to help improve and maintain the skills they need for daily living and working, such as getting dressed and using a pencil. And speech language pathologists are experts in communication and swallowing disorders. So they help patients improve their language and social communication. And these are all the members of our team, and we work closely with them. We tend to be the leaders of these teams. We are the ones who prescribe these therapies. So just like any other physician might prescribe a medication, we prescribe occupational therapy and physical therapy. We also work closely with patients to provide them with adaptive devices as needed. So some of these include prosthetics, which are artificially made limbs that replace a part of the body that's missing. Orthotics, those are devices that are used to correct or enhance the function of a body part. So you may be familiar with some of those terms already. Additionally, we perform other procedures such as acupuncture, platelet-rich plasma injections, which are all relatively new and are still undergoing additional randomized controlled trials to show efficacy of these injections, but those are other things that we are familiar with. All right. So I thought that it would be, to help you all kind of understand what exactly we do, I thought it would be useful to go over a few case studies. And I have one that involves patients both on the inpatient rehabilitation side, so inside the hospital, as well as an outpatient clinic. So the first patient I want to tell you about, I think it's relevant right now. It's a 49-year-old male, and he has a history of leukemia. And he comes to us in inpatient rehabilitation, and we see him because he's deconditioned after hospitalization for COVID-19. So as physiatrists, we also have to understand a little bit about his background and medical history. And so this male, he was an otherwise healthy male, but he was diagnosed with chronic myeloid leukemia with blast crisis earlier this year. And for that, he underwent 5 cycles of chemotherapy. He was otherwise doing fine, no other real past medical history aside from that, and staying active, working in his yard until September of 2020. At that time, he was brought to the ED with 1 week of generalized weakness and confusion. He couldn't give us a clear history, so to the emergency medicine doctors, his wife, they spoke with his wife, who said that he was slow to respond to questions, not making sense, and doing really nonsensical things like putting towels in the toilet. So they admitted him to the hospital. He underwent extensive infectious and cancer workup that included things like a chest x-ray, urinalysis, and head imaging. And those were all negative for another cause for his symptoms. And the only thing that was positive was his his COVID PCR test. And while he was in the hospital, he was seen by different specialists who felt that his altered mental status or his encephalopathy was unrelated to his leukemia, chemotherapy, or other cause. And they felt that this confusion was really due to the neuropsychological sequelae of COVID-19 infection. So after this acute hospitalization, he was sent to us. And I want to take a moment to recognize that there was a lot that happened. We as physiatrists even saw him. And so even though all that happened, it's important for us to understand his medical course because that sheds light on his recovery. For example, how long he has been in the hospital, what conditions he may have had, and any complications that he had during his hospitalization would give us an idea for how deconditioned he is, how much therapy he might need, and whether he might need assistance transitioning from that acute inpatient hospital stay to back home, ideally. So back to seeing him in inpatient rehabilitation, some of the reasons he's also coming to us include decreased strength, dependence with his ADLs and IADLs, as well as cognitive impairment. So ADL stands for activities of daily living. Those are things like eating, bathing, getting dressed, toileting. Stand for instrumental activities of daily living. So these are slightly more complex skills that include things like cooking, driving, caring for pets, completing housework, using a phone or computer, shopping, managing finances, similar to ADLs, but more complicated. And both of these things, ADLs and IADLs, are important as evident in the name for being able to live and function independently. Finally, the last reason, cognitive impairment, describes an impairment in his ability to think, plan, and remember or learn new things, and make decisions in his everyday life. So now we finally understand why he is here. What do we do as physiatrists? So this patient arrives to us on the inpatient rehabilitation floor. We go and meet him and his wife. We've already read through his medical chart and understand the things that happened before he got to the hospital and what happened in the hospital. And now it's our time to get to know him and understand what his life was like before he came to the hospital so that we can understand what we are trying to get him to and transition him back to. Some of the specific things that we specifically care about are his social history. So things that include like how much he smokes, drinks alcohol, and if he does other drugs. But other aspects of his social history that are also important to us are things like his level of education that can impact what his cognitive baseline is, his employment. So if he works at a job that requires intricate use of his hands, things like dentistry or machining that might need a little bit more work with our occupational therapist, for example. Also, with his employment, if he's up and walking around all day, that is going to require different intensity in therapy compared to if he spends most of his days sitting at a desk. This helps us understand whether he needs an assistive device or accommodations at work as well. We ask about his hobbies and about how active he is because our goal is to be able to get him back to doing all of these things. We also really want to understand his living environment. So how many steps he has at home, because we'll have to work on getting him to be able to climb stairs if we want him to function independently at home. It's helpful to know if he lives in an apartment building, if he lives in an elevator or a trailer. Does he have a tub shower with accommodations like a railing? All these things help us understand whether he's safe to go home and whether he might need other assistance like home health services. We also want to understand his functional status. So what is he able to do right now? Can he get out of bed? How far is he from his goal, from what he was doing before he came to the hospital? And what are our goals for him? So for this patient in particular, he was a non-smoker, non-drinker. He worked on a 7-acre farm in Middle Tennessee and was very active on his feet. He spent most of his days actually driving around on a tractor, and he was functionally independent. He lived with his wife and 2 children who were 12 and 15 years of age, and they all depended on him. So knowing all these things, we kind of understand where he came from and what he and his wife are expecting him to be able to do after his inpatient rehabilitation stay. We do our physical exam and assess how he's doing right now. So in addition to listening to his heart and lungs, we do a focused exam on his strength, like his musculoskeletal exam, as well as his neurologic exam. In our patient, he had some weakness in his lower extremities. He's generally deconditioned from being in the hospital. So for that, he worked closely with our physical therapist to improve his strength. And the thing that was really, that stood out for him was his cognitive status. So cognitively, he was very far from baseline. We found that he needed maximum cueing for simple commands. So he had a lot of difficulty initiating tasks. He was very distractible, very fidgety, and very far from being cognitively independent where he was before. So for that, he was seen by neuropsychology as well as speech, language, and pathology to work on speaking and communication. And we worked with him to develop routines and practice problem-solving skills. So while he's in our inpatient rehabilitation hospital, we prescribe these therapies like physical therapy, neuropsychology, and monitor his improvement over the course of time. Medical things came up while he was there with us, such as agitation, confusion, pain. When he's working with our therapist, we always expect some level of pain because he, as you're getting up and being more active, that can cause a lot of musculoskeletal pain. And those are some of the things that we both manage as well as treat. And for other patients, not necessarily for him, but if they develop new shortness of breath, for example, or other things that can be managed on in a less acute hospital setting, we as physiatrists will work this up with potential lab tests, imaging, and treat as needed too. So we are ultimately seen, I kind of like to think of us as the primary care physicians in the inpatient rehabilitation hospital. And one more thing for this case that I want to emphasize is that rehabilitation is an ongoing process. So his cognitive rehabilitation is still ongoing for this patient. We know that there are a lot of neurologic manifestations of COVID-19, and recovering from COVID-19 or any disease really can take time. The trajectory is different for every patient. So his time in the inpatient rehabilitation setting is just a small slice of his whole rehabilitation trajectory. And we often have these patients continue therapy in outpatient, and we continue to see them in clinic as well. So I think, Reagan, with that, we were going to pause for a second to take questions. Is that right?
Yes, ma'am. We have a lot. So let's see. So would you say that you take a much more holistic approach to treatment and rehabilitation compared to other specialties?
Yeah. So I think that that's one of the things that I love about our specialty as well too. We work, our entire team is very multidisciplinary, and we work with a lot of really great healthcare providers, the physical therapists, occupational therapists, nutritionists, psychologists. A lot of these other healthcare providers are very are part of our team, and we depend a lot on them.
Okay, and then let's see, there's a lot. So a lot of the students wanted to know if you had any input on the projected job outlook for PM&R, knowing that not very many people are very well versed in it or even know about it. So they just wanted to see, what the job outlook was for that.
Yeah, that's a great question. So I'm biased, first of all, but I think that, especially as our population survives a lot longer, we're going to have a lot more comorbid conditions, and what's going to be affecting our quality of life are a lot of these conditions, chronic conditions that cause us to be debilitated. And just an example being coronavirus and COVID-19, we're still seeing a lot of those effects on our patients. And I think that I'm very optimistic about the continued need for rehabilitation, especially because I think that any patient can benefit from a physician who can really focus on their function and quality of life. And especially as we age, I think that what will become very important and valuable for a lot of patients is their ability to maintain quality of life. So I'm optimistic that, our field is still growing, where we have had a lot of several residencies actually pop up within the past few years. But I think that kind of is good. To know that it's kind of an up and coming with more residencies popping up.
Most definitely. Yeah. I think that it's going to definitely be more popular within the next, 10 years. I think people are starting to look more into that type of medicine and specialty. And then what do you suggest as clinical experiences for those who want to learn more about physiatry? And is that a rotation that occurs in medical school?
Yeah. So it depends on the medical school. Some medical schools don't have like a physiatry department, for example, but others kind of loop the PM&R rotation into either like the musculoskeletal block or the neurology block. I think for me, quite honestly, had I not had mentors in physiatry, I probably wouldn't know about this field. And I think that we're working really hard to kind of get our name out there. I think it's one of those things where you kind of know about it and then you pursue it, or you hear about it late in medical school and then you become interested. But I think that one of the things I'm trying to do too is finding mentors within the field. And I hope that I, can be a mentor to other students too, to spread the word about PM&R.
Yeah, definitely. And then one of the students said that they see a lot of osteopathic physicians in PM&R compared to physicians who obtain an MD degree. And they wanted to know, had you ever thought about pursuing a institution that was osteopathic in philosophy?
Yeah, I certainly did. I think that, we work very closely with osteopathic physicians as well too. So I think that the huge benefit also is that I can't remember how many hours of OMM and more like musculoskeletal training you have as a DO, but I think that is really beneficial and helpful. And I actually am trying to get one of my co-residents to teach me a little bit about that. But it certainly is I think it's great training for physiatry.
Yeah, seems like it. And then a lot of the students in the chat are having some difficulty with understanding kind of the differences between what a physical therapist is compared to what a physiatrist is, and why you chose being a physiatry physician compared to a physical therapist.
Yeah, that's a great question. We actually get that all the time. So physical therapists, they are the ones who are actually doing the therapies with the patients. Physiatrists, we go through medical school, we have the medical training, and we don't do the therapies with the patients. We kind of oversee the entire rehabilitation process. Part of what makes us different, actually, I get this question a lot, is, why go through medical school and become a physiatrist rather than go to physical therapy school and become a physical therapist? And I think that the big distinguishing thing is that as physiatrists, we are also, in some ways, we manage more of the medical conditions as opposed to like the musculoskeletal conditions. And we're more knowledgeable in things like, like high blood pressure, hypertension, or hyperlipidemia, or high cholesterol. We manage a lot of those medical problems. If you're interested in doing the therapies and getting to work with the patients directly, then physical therapy is kind of the route to take for that.
Gotcha. That makes so much more sense. Thank you. And I think we'll do one or two more. So Has your background in engineering helped you as a physiatrist? And they wanted to know, do you use your product design experience in your role?
Yeah. So my product design background. So actually, I just started doing research again with some of my mentors who first showed me about physiatry. So I'm working closely with the Stanford group. So my particular interest is in sports medicine, and I'm doing research with them. My background in product design, it's really helpful. I think especially in the Bay Area, because people are really interested in kind of like entrepreneurship and innovation and healthcare, health tech and startups. And so I've been helping them with some of the health technology companies that we're hoping to get, hoping to become a part of our project. So like things like working with, and this isn't specifically with that group in general, but in the past, like working with Fitbit on a past like product design project, or other companies like Strava or Headspace. Those are all kind of health tech companies that aren't quite like FDA medically, undergoing those rigorous medical testing type companies, but those are certainly companies that product design kind of helps bridge that gap between being a physician and being an engineer and working with those companies. And then I think the second question was, how am I using my engineering degree right now, I think. So I think that one of the great things about pursuing the things that you love, and if you would have told me this several years ago, I would have been like, no, like you should just get through medical school and don't think too hard about it. But pursuing the things you love, like I love product design, and I think that there's many things that you can do with it. I've had attendings come up to me, and I'm still a resident, I'm still in training, but they kind of find out about my background, they find out about my interests, and they loop me in. They just find it to be a very unique thing. So one of the things that I'm also doing right now is I got involved with Vanderbilt's business school, entrepreneurship center through the business school. And I'm actually working with some startups, and I'm just advising them on some of like the health startups specifically, advising them on some of their products, trying to use my product design background, but really also emphasizing my kind of medical training. But I think that was the big thing that I've realized is when you do what you love, people kind of start to find you. Like I found that opportunity that I don't think that I really would have found or would have been qualified to had I not had a background in engineering and design. So there's certainly ways to do it. I think it's easier once you get out and practice and you're able to control, and you're an attending and you can control your career a little bit more, but certainly ways to use an engineering background.
Well, cool. It sounds like you're just a queen that dabbles in everything. So
Yeah, may I ask, one of this long hauler syndrome, and one of our learners brought up that point too. Are you seeing pretty big neurological kind of devastating kind of long hauler syndromes in your field as a result of COVID-19?
Well, I don't know if I've heard that term before. Can you explain that to me?
Yeah, just long-lasting effects after infection with COVID-19, and so ranging from neurological to respiratory to pain, myalgias, etc. So I think we're going to be seeing more and more of these patients. We already are.
Yeah.
The neuropsychiatric conditions of the patient you presented, Thea, are some of the long hauler type symptoms, everything from headache to fatigue to malaise to anxiety, neurosis, depression, and so forth.
Yeah, I'm going to write that down so I can up because I hadn't heard of it. But I mean, certainly. And we had just realized that a lot of these patients are coming to us in inpatient rehabilitation. I think today we were just talking about how some of the medicine patients that we had seen after, we see them, after they've had like a stent placed, or after they had a heart attack, or if they've had a transplant. But now we're actually seeing more and more patients just after COVID, whether that's because, they had this really prolonged hospitalization, and like our patient, he now has encephalopathy and needs rehabilitation, but we're seeing a lot more of those. So
Thea, let me ask a question before we go back
Yeah.
to your what a wonderful presentation. I just love this. We work very closely at my shop and Gil's shop with the PM&R folks, and I'm always quite honored. Actually, one of our PM&R professors at Southwestern leads what we call our JAMP program, which is for the Joint Enrollment Program for pre-med students. So it's, we love our PM&R folks. I see in my work at Parkland, and Gil does too, a tremendous number of people who are very much at the end of their lives. They have cancer, it's metastatic, they're horribly disabled and so forth. And so in your work as a physiatrist, do you get involved much with end of life planning for, could you expand on that just for a moment?
Yeah. And I, a little bit later, I'll also kind of talk about the different paths you can take after you specialize in PM&R, but one of them being palliative care. We have a physician also who specialized in palliative care as well as cancer rehabilitation. And that's actually another reason I chose PM&R because, ultimately we want patients to have the best quality of life that they can have. And I think most patients will agree that, and not all certainly, but quality of life is more important to them than quantity. And that's certainly something that, palliative care fellowships are things that we as residents can pursue after PM&R as well too. And we have quite a few physiatrists interested in that.
That's wonderful. Well, what an exciting presentation. Let's hear the second half.
Well, thank you. All right. And can you still see my screen?
Absolutely.
Okay, perfect. Let's see. So I'm going to move this down. So my next case, or one more, is a case that you might see if you're working in an outpatient rehabilitation setting. And here you'll probably see that as outpatient physiatrists, this involves a little bit more diagnosis and treatment, as opposed to, you'll see the contrast between outpatient and inpatient. So we're going to talk about knee pain, specifically in a 19-year-old runner. So this runner presents to our clinic, and briefly, I'm just going to talk about anatomy because this is very important to physiatrists, and I'm kind of just give like a 2-minute overview of the knee. But the knee is a modified hinge joint. It's the largest joint in the body, and it is susceptible to injury because it rests at this long lever arm of the tibia and femur. The knee is the spot where the femur and the tibia join up and articulate. And on top of those bones, there are the muscles, which include the knee extensors, the flexors, your rotators, and the popliteus muscle, which unlocks the knee. You also have the ligaments of the knee, which include the ACL, PCL, MCL, and LCL. And usually as physiatrists, and especially me as a resident, I kind of actually review the knee anatomy in real life, even before going to see a patient, because anatomy is pretty important for musculoskeletal outpatient PM&R. So let's jump into the case and just get a little bit more history from this patient now that we've caught ourselves up and reviewed the anatomy of the knee. And we're going to obtain a history. And when we obtain a history, I like to use this mnemonic OPQRST. And I like to apply this to every patient I can, but really patients who come in with pain, this is useful for. And so OPQRST stands for onset, provocation, and palliation, quality, radiation or radiation, or region or radiation, severity, and timing. So in our patient, the knee pain, we get a little bit more history from her. The knee pain or the onset began several months ago. It is provoked with walking down the stairs and running down hills. She has stiffness after sitting for a long time, and she often or crackling sound in her knee after prolonged sitting. The pain is located at the front or anterior region of the knee, and she rates the pain on a scale of 1 to 10 as a 5 in severity. So we get that history, we do a physical exam, and we take a look at the knee. So when we're looking at the knee, on our exam, we assess for areas of tenderness, amount of swelling, range of motion. And we can also, the thing I love about outpatient musculoskeletal medicine is that we do a lot of specialized tests. So if we're concerned about specific disease, we can do a lot of tests on the knees. And this can also help us guide our clinical judgment as to whether we need further imaging. So after we do all these tests in this patient, we'll go ahead and get an x-ray, and we're looking for fractures and bony abnormalities. Specifically, the x-ray will help us visualize the location of the patella and femur and detect any abnormalities as well. So we get the x-ray after this work. We diagnose this patient with a condition called patellofemoral pain syndrome, or runner's knee. It's an anterior knee pain that is caused by improper tracking of the patella along the distal femur. So in that image, you can see the patella against the femur. And if it doesn't track properly, this can cause pain. If we take the x-rays, as I had mentioned earlier, if we take those at different angles, we're able to see when her kneecap goes off track. And our suspicion for patellofemoral pain syndrome is high based on her history. Her history actually gives us a lot because she's a runner with knee pain that is worse when going down hills. Sorry. Quick drink of water. So it's a very common complaint seeing in young women, especially runners. And patellofemoral pain syndrome results from a combination of structural factors, muscular imbalance, as well as quadriceps weakness. So we have our diagnosis, and then we focus on treatment. And a lot of this, the treatment for this will involve activity modification and correcting any incorrect running form or mechanics that may be contributing to the pain. Rest, ice, and NSAIDs are really the foundation for this musculoskeletal complaint, and then physical therapy. So it'll be important for her to work on strengthening her quadriceps, strengthening and stretching the hamstrings, IT band, and adductors. And she can also consider knee bracing or patellar knee sleeve with a patellar cutout. That can prevent re-injury and allow the patient to resume activity. Taping is another thing that can be done, and that is theoretically allows proper tracking of the patella. And as a last resort, if her pain is just unbearable and there are other structural abnormalities, consulting to orthopedic surgery is a last resort. So now that we've talked about being what it's like to be an inpatient physiatrist and an outpatient physiatrist, I'd just like to go back to how to become a physiatrist. Physiatry is a medical specialty, and as becoming a doctor really is, there's several years of training. So after completing high school, you have an additional 12 to 13 years of training in order to become a physiatrist. So that includes undergrad and medical school. After you graduate from medical school, you do 1 year of internship, which is usually in internal medicine, surgery, or transitional year. So I did a 1 year internship in internal medicine, and that kind of is really what makes us, I know that we talked a little bit earlier about physiatry versus physical therapy. I think that 1 year in internal medicine really helps to illustrate those conditions that we see in internal medicine as the foundation for physiatry training, kind of what makes us different than physical therapy. So after that training, residency is 3 years. You can do a 1 to 2 year of fellowship. I should actually say 1 to 2 year of fellowship if you like. There's over 30 PM&R residency programs in the US, and fellowships are really optional since physiatry is a specialty. Theoretically, you should be able to do a lot of the things that you'd want to do as a specialist after physiatry residency, but up to a little bit of, up to under half of physiatrists actually complete a fellowship. So 43% end up choosing to pursue that route. And so people often like to ask me what residency is like, since I'm a resident myself. And residency programs, you know, I don't think you should choose a specialty based off of residency, but residency in physiatry can be pretty enjoyable. Programs tend to be pretty small. Usually the class size ranges from 2 to 14 residents per class. So in my class, we have a total of 4 residents per year. In terms of requirements to complete residency, it's pretty simple. You have 12 months of required inpatient rotations. So here are some examples of inpatient rotations and the teams that you might be managing. So you might see general reconditioning or deconditioning, neurologic disorders, stroke, brain injury, and spinal cord injury. And then as far as outpatient rotations, you have 12 months of outpatient, and there are a handful of outpatient rotations, some required depending on the program you decide to you choose, and others which you can pick from as electives. So some outpatient rotations include amputee clinics, EMGs, spine, sports medicine. Those are some of the really popular electives. And then finally, you have 12 months, an additional 12 months on that, which are a combination of inpatient and outpatient months. And that really depends on your program, but there's opportunity, at least at our program, to really kind of specialize and figure out what it is you want to do with your career. You also have a maximum of 6 months for research and residency program. And there's opportunity to become a rehab medicine scientist, and there's certain programs for that as well too. Call is another thing that more so residents like to ask me about, medical students like to ask me about, but just briefly, we take about 8 weekend calls our first year, our second year, I guess, as PM&R residents, and we take progressively less calls. So life as a resident, I end up having most of my weekends free, which is pretty rare for residency. That is a great opportunity if you're someone who knows what you want to do. If you like to become involved in other extracurricular opportunities, I know there were some students who had asked about like engineering and product design and how to combine that, or how I've been able to combine that with PM&R. But there's certainly opportunities to do that in residency, even in residency as a physiatrist. And other things that you can do in terms of extracurricular opportunities includes recruitment, helping to just spread the word about PM&R, working with pre-medical students, pre-health students, doing research opportunities for mentorship and involvement. And as I'd mentioned earlier, working with, if you have an interest in entrepreneurship and design, that's one thing that I've been able to do in residency as well. So I've been able to stay close to my non-traditional path and kind of make the most of all my experiences. So I feel very fortunate that I found a specialty that in which I've been able to do these things and kind of start building my career even as a resident.
What sort of fellowship might you think about, Thea?
Yeah, so that I'm glad you asked that. So I have a slide on fellowships. For me, so I'll go over all of the fellowships, but in theory, it's, as I mentioned, it's not technically required, but if you want to do that extra 1 to 2 year of training, there are many fellowships that you can pursue. So just scanning this list, we talked a little bit about hospice and palliative care medicine, which is a great and very, very meaningful specialization within PM&R, but within other medical specialties as well too. There's neuromuscular medicine, pain, pediatric rehabilitation. So if you're interested in pediatrics and working with that population, there's a very big need for that as well. Traumatic brain injury patients. And then there's other, they're non-ACGME accredited fellowships, and we can talk a little bit about that if it matters to anyone. But there's also other things that you can do, like cancer rehabilitation, research, interventional spine as well too. So let's see. Mm-hmm. Did you have a question, Dr. Fowler?
Well, I was just going to comment, it's interesting. Can you go back to the previous slide?
Yeah.
Do you mind?
Of course.
One of our recent grads is doing a year in sports medicine here in Fort Worth, and then we're trying to recruit her back as a faculty member to actually start a sports medicine program. But the reason I bring this up is that it's interesting how some of these various fellowships can be approached from different residencies.
Certainly. Yeah. Certainly. And I think that that's actually a great point, because for sports medicine, for example, you can go through pediatrics, you can go through family medicine, you can go through emergency medicine too. So there's a lot of different ways to get to this fellowship. And I can talk a little bit about sports medicine in particular because that's my interest. But one of the reasons why I chose PM&R as a route into sports medicine is that as physiatrists, in residency, you get a lot of training in musculoskeletal medicine. We have an ultrasound curriculum. We get a lot of experiences with procedures. And so, it really just depends on what kind of training you want to do. For example, emergency medicine, that is great training if you want to be a sideline doctor where you have to take care of, on the field emergencies. I think internal medicine or family medicine is a great path as well too. With that, you manage more of like asthma, kind of like you're the primary care doctor for athletes, but there's multiple ways to approach it. And your background training can help you figure out what kind of path you want to take into a particular fellowship, for example.
I think it's really useful, Thea, to look at what you presented there. Hospice palliative is really kind of an end of life sort of thing. Neuromuscular can be any of the broad range of how people can be challenged. Somebody with an amputation in the military and so on and so on. Pain is its own area where people can have awful problems controlling chronic pain from various reasons. Spinal cord, sports medicine, and so forth. So look at that broad range of what you can touch on from your field. Could you explain for a moment the difference between ACGME accredited and what non-ACGME accredited means?
Sure. So ACGME, that stands for the Accreditation Council for Graduate Medical Education. So accreditation is overseen by a review committee. So much like medical schools, they set accreditation standards and provide, what they say, at least on their website, is that they provide assurance that certain programs meet quality standards. Non-ACGME accredited fellowships, actually don't know why there is that difference except for the accreditation part. But I think that they're equally, some people like to think that the ACGME accredited fellowships are more competitive. But I think non-ACGME accredited fellowships, if you're doing what you love at the end of the day, the distinction.
The other thing is that with ACGME, you have an assembled body of knowledge that you can sit for an accrediting exam and become board certified in that specialty. Whereas in non-ACGME, basically, for example, cancer rehab, you can go study that for a couple of years, but at least at this time, there's not an accrediting examination. My own field and Dr. Salazar's own field of emergency medical services went from non-accredited to accredited a few years ago.
Okay, thank you.
It doesn't make him any less important. It's just as the fellowship, as the body of knowledge increases, you start getting more specialists, greater training, and then you develop a godforsaken board certification exam, which is not a lot of fun.
Certainly. All right. Let's see. Shall we go to the next slide and talk a little bit about life after training? So after all of this training is over, what you'll spend most of your life doing as a practicing physiatrist, what does that look like? So physiatrists, depending on if you choose to pursue fellowship, that can also affect what happens after residency, but we work in a variety of environments that include inpatient, outpatient, and consulting roles. We practice in academic settings, group practices, as well as solo practices. So some of the places where you might see a physiatrist include a sports medicine clinic, neurology clinics, an acute care hospital, so perhaps like in a consulting role, a rehabilitation hospital, so a subacute facility, or a skilled nursing facility, a nursing home, and others. And as mentioned earlier, PM&R is a team sport. So we work with a lot of other medical professionals, and we might, as a physiatrist, you might interact with other physicians that include neurologists, orthopedic surgeons, emergency medicine doctors certainly as well too. And then the physical therapists, occupational therapists, respiratory therapists, and nurses are also part of our team. And we work closely with them. And I especially rely a lot on their expertise and knowledge as well too. So there are many reasons to choose physiatry, only some of which I've listed here, but here are some of my reasons. Physiatry is an incredibly meaningful specialty, and that leads to an incredibly meaningful career. Most patients, don't want to be in the hospital. Most patients are scared of doctors. And most patients are probably scared of physiatrists too, but many of our patients are excited to see us because they want to get better. They're motivated. They ultimately, when they decide to choose a physiatrist, they want their function and quality of life to improve. It's incredibly meaningful to work with these patients. So whether they're young or old, they've just suffered a traumatic event that's life-changing, like a spinal cord injury or a brain injury. It's really meaningful to help them adapt to these new disabilities and get back out to living their lives. We're also able to follow our patients longitudinally, and we build very meaningful relationships with our patients. We also work with a diverse patient population. So as a physiatrist, briefly mentioned earlier, but you can really choose the type of patient you want to work with, whether that's pediatrics, paraplegics, Olympic athletes, even if you wanted, or if you wanted to specialize in women's health. There's also a newer, smaller field coming out that's pelvic floor rehabilitation that works specifically with women's health. So again, I just like to reemphasize that anyone can benefit from a physiatrist. Physiatry is also a multidisciplinary field. So if you like neurology and musculoskeletal medicine, I think that you can do both as a physiatrist. You also get to work in a team with other physicians, and you also get to lead a team, which I think is really fun and really meaningful. And lastly, physiatry is full of opportunities. I think that it's both a good and a bad thing that we're kind of a new and relatively lesser known specialty. I like it because I think you can make it what you want it to be. Physiatry also gives you the opportunity to do things. Ultimately, the opportunities are, I think, the biggest draw of PM&R and a big reason why I chose this field. And so lastly, I just kind of wanted to end with some advice that I like to give students. And I have 3 of them. So my first advice is to pace yourself. So everyone always told me that medicine is a marathon, not a sprint. And it truly is. When you enter medicine, you'll realize that exams and being graded, that never really ends. Realize to not look too far into the future and to really concentrate on what you're doing now, because doing a great job with what you are currently doing will open more and more doors. And, I was very guilty of being that college student that said, once I go to medical school, once I take step 3, once I take all these board exams, once I get into residency, I can finally do the things I want to do and be happy. And I think in some ways I kept using that next big accomplishment as an excuse to not enjoy the moment and enjoy and love what I was doing in that moment. And so, especially now as a resident, I realized that, I just took my last board exam a few months ago, and I'm already starting to study for my next one. And it's really kind of at this point, and you really just have to pace yourself and be happy with what you're doing. My second piece of advice is that you should embrace opportunity. I think that when you really enjoy what you're doing, it opens you up to be free and as well as willing to embrace opportunity. So when I was in high school and I got to Stanford, as I'd mentioned, I just felt very out of my league. A lot of people just seemed to know what they were doing, whether they knew they wanted to, be a founder of a company or to go into dentistry or to even, I had friends who just wanted to stay home and be parents, and all those things. I just wondered why, like, everyone seemed to know what they wanted to do and seemed to have their passions. And I really just felt like for a while, like I didn't know what I wanted to do. And so in light of that, one of the things I did was I tried a lot of different things. And sometimes I look back and think, if I had just known what I wanted to do right away, because, everyone seems to know what they want to do right away. Maybe I would have had an easier time. Maybe I would have been able to be a little bit happier. But looking back, I realized that had I not embraced certain opportunities, had I not majored in product design or taken that musculoskeletal lifestyle medicine class, taught by those physiatrists, I probably wouldn't be doing what I'm doing now. And I try to emulate people who I think have really interesting careers. And I found that people who do those things have tried many different things and found ways to combine different disciplines. So I've tried to copy a lot of these people, and especially when you are, still early in your career, trying to figure out a lot of different things. I think that figuring out what you want to spend your life doing and trying things that come up have been really helpful for me. And the last and probably the most important thing that I've learned is to keep your friends and family close. I think that's a little cliche, but I've realized that being happy in life is really about making time for your family and friends. And I say that when I went to medical school, I lived with my parents. As a resident, I lived very close to my in-laws. And I try to make time for my college friends. I try to call them often. And I realized that this is so important because without their support, I wouldn't be where I am today. So I just wanted to leave you all with a few references and resources if you're interested in learning more about physiatry. And then I think that one of the things that I've learned, especially throughout this journey, is that mentorship is so important, and being able to talk to a lot of different people and hear their experiences, hear things that you want to see in your career by seeing what other people are doing and maybe things that you don't want to copy from other people, has been so important to me and so helpful to me. So I always just like to leave my contact information. Really found that Instagram or Medstagram now is a great way to to get in contact with some of these groups. So please feel free to reach out to me. You can also reach out to me on Twitter as well. And I'm happy to take other questions. I also just want to thank you guys again for your time and for your great questions. I always think that I learn a lot from you all with your questions as well too. So I appreciate it.
Thea, what a wonderful talk. In the ER, we see so many old, frail people all the time. And, you might say from an acute or emergent physiatrist sort of thing, we have to be careful about sending them home because their greatest risk is that they may fall.
Certainly.
Getting my new young EM residents, to come in and say, now, you determined it's not a heart attack and it's not pneumonia, but look at this person. They can't even get back and forth to the bathroom. And if she goes home and breaks her hip, she's going to die. And so I was wondering if you would comment about the sort of more acute aspects of physiatry and about how you decide that people are, for example, safe to be at home and when you can make that decision.
Certainly. And I think that's a great question and a great point. I think a lot of times, we don't realize it, but people are kind of, people are at home, but they're kind of teetering on the edge in some ways until they have that, sentinel event, and they either have a fall or they come up with a pneumonia or something that brings them to our attention, to the healthcare system's attention. I think that one of the things that we, at least in our hospital, are building out is our consult service. So I think that that's actually a huge opportunity for physiatrists because especially in the emergency department, perhaps you don't want to admit them to the hospital. Perhaps for them, maybe home health services would be helpful, or maybe they just need a little bit of rehabilitation. We see plenty of elderly patients mostly, but who have had falls simply because they've been deconditioned and they've, maybe had like outpatient problems like pneumonias that were treated outpatient. And then finally they just have a fall, or the weakness just kind of gets to them. And then they come to the emergency department, and really their diagnosis in the ED is weakness. But I think, as physiatrists, we have an opportunity to offer another form of treatment for that, which includes intensive inpatient therapies, maybe a closer look at some of the ways that we can help them in their homes, like with home health services, as I mentioned earlier too. So
I would imagine that connection with skilled nursing facilities is one of the things that you really have to do in your work, I would imagine.
Certainly. Yeah, certainly. And even from inpatient rehabilitation, some physiatrists after residency too choose to work in a nursing facility. That's actually a great career choice. It's very meaningful actually too, because at least I personally love working with that population. So.
Well, I think Reagan has got a fistful of questions to ask you if your time can stay with us a few more minutes.
Of course, I'm happy to answer them.
Perfect. I won't take up too much more of your time, but we do have just a few more questions that I wanted to ask. So like I mentioned in our pre-meeting chat, we have a lot of pre-PA students in our program, and they wanted to know, are there opportunities for PAs in the field of PM&R?
Certainly, yeah. So my friend's actually a PA, and I'm trying to convince her to go into PM&R. But in our hospital in particular, we have. I guess I don't personally work with a lot of PAs in the inpatient side. We do have nurse practitioners who work with us, and they function. They work closely with an attending, but they function, I'd say, pretty close to the level of a resident. In the inpatient side, I know that outpatient musculoskeletal clinics, they do have a lot of PAs, kind of like orthopedics has PAs. But there's certainly opportunity, I would think, for PAs within the inpatient side. I don't think we have them in our hospital, but outpatient, certainly we have them.
Cool, perfect. And then a lot of students wanted to know what the work-life balance was for a typical PM&R physician. Like, do you have weekends off? Do you get off at 5 p.m.? Is it kind of like a PCP?
Asking the great questions. So yes. So the great thing about PM&R is that that work-life balance in some ways starts in residency as well too. We, as I mentioned, we have a lot of weekends off in residency. And as an outpatient, and it really just gets better each year, but we have, most physiatrists have weekends off. Depending on if you're inpatient or outpatient, it can look pretty different, but as a resident, we have weekends off. We take call, several times a month. In terms of hours, it depends on if you're inpatient or outpatient. Outpatient, I think clinics tend to start at 8, and you're usually done by 4. We have physiatrists who are out earlier than that. It kind of depends on how efficient you are and how many patients you want to see. But on the inpatient side, I get in as a resident at, say, between 8 and 9 a.m. And I'm usually out by 5. I think like 7 is the latest, probably 5 to 7. So overnight call, that when you're an attending, I think that just gets better. Because even on the inpatient side, you have a resident working for you. You might take call. It depends on your practice, how much you take call. But it's certainly, and this was important for me, it's a field that I think is great for work life as well as family balance. And that was one of the reasons why I heavily chose this field as well.
Perfect. Yeah, it sounds like a really wonderful balance there. And then I think this will probably be our last question because it might take a little bit of explanation. So with one of the main philosophies of this field being prevention, are there any ongoing efforts in the field that combine with public health to promote prevention of certain conditions in at-risk communities?
Mm-hmm. I think that's a great question. So I personally, though, I don't know of anything happening, but I think that with PM&R, if you understand our philosophy and you receive our training, I don't see why you wouldn't be able to be involved in public health initiatives. I think that if you have, I don't know if the person who's asking this has an MPH or specific interest in public health, but I certainly think that there is a role for PM&R to do those things. After residency, one of our residents pursued a quality improvement type of fellowship. So she was really interested in hospital systems and working to improve the hospital system itself. That's actually something I'm interested in too. But, after receiving this training, your career could look, it doesn't have to be strictly clinical, is what I would say. I think that there's certainly opportunities to, if you love clinical work and you love working with patients, you can certainly do that full time. You can also do research. You can also, if you're passionate, and I think this is true about a lot of fields in medicine too. I think having that degree really opens a lot of doors. So if you are interested in public health initiatives, I certainly think that PM&R is a specialty that you can do those sorts of things. But I also think that there's other fields too, where medicine has just opened all these doors for you to make your career what you want it to be.
Perfect. And I think one more question, because they are in the chat and they're going crazy. So
feel free to
ask. Okay, so they know that you didn't have a typical pre-med undergrad, education on biology and all that other stuff, all the pre-med classes, so they wanted to know, as a non-traditional student, how did you go into medical school feeling based off of like content, and how well prepared did you feel, and did you do anything to prepare for that?
Yeah. So I can back up a little bit and kind of tell you what classes and how I thought about my medical journey. Because I actually when I started college, I'd taken, I think, like half of my biology classes because I thought maybe I wanted to do biomedical engineering. And then I decided I didn't want to do that. And then it was like my senior year where I decided that, I think that what I'm interested in is this product design, healthcare systems design from a medical perspective. And I think I want to go to medical school. So I ended up taking the other half of my biology requirements and pre-med requirements. I squeezed them to the very end of my senior year. So I would not recommend that if you can help it. But, I did that. I've been there. I took an extra semester of classes. At Stanford, there's this program called the co-term program, where you can actually get a master's degree for taking extra classes. So I started taking classes towards my master's in biology. I ended up not finishing it because I ended up getting into medical school, and I still had a bunch of requirements to do that I decided, that my advisor mostly told me that I shouldn't stick around for. But I did take an extra quarter or two, I think it was 2 quarters of biology classes to complete my pre-med requirements. During that time, I was studying for the MCAT. I was working at some technology companies and design companies in the Bay Area to kind of fill my time as I was studying for the MCAT, and really dedicated myself to that. And ultimately, it turned out to be kind of me spinning myself in circles for a few years, deciding I wanted to go to medical school, and then really tunnel visioning myself into getting into medical school. So not the most fun. I think in medical school, one of the things that I've realized is that there's, pros and cons to every path that you choose. So if you are a biology major and you are, or a chemistry major, some of my friends in medical school had a lot easier time than me. So I, oftentimes didn't know what was going on and had to ask my friends who had majored in biochemistry or biology, and were seeing this for the second or third time, to kind of help explain things to me. I certainly, seeing things for the first time in medical school can be really difficult. So I would say that medical school wasn't easy for me. I spent a lot of time studying and kind of making up for that time that I spent doing other things in college. But it was certainly doable. So I think it really depends on, how you approach it. I hope that answers that question.
Yeah, definitely. I think that was the last one. So Dr. Fowler, Dr. Salzer, do you have any last questions for her?
Oh, Phil,
Yeah,
you go first, Gil.
Oh, yeah. One of the questions somebody has was about collegiality. If you're looked down upon by other specialties, I'll tell you what, being kind of in a middle generation here between the old school and the new school, I think there is a lot more camaraderie, a lot more mingling of specialties. So now my residents who are young, they know every single resident in every other specialty, and in their buddies. I'm not sure that was the case 10, 15 years ago. So I wanted to see if you might comment about kind of the new generation of physicians coming out and the networking that takes place with other folks in the healthcare arena.
Certainly. And I'm not sure if I'm understanding this question exactly, the comment that was made earlier, but I do think that, physiatrists for the longest time, and, to admit this, it was thought that physiatry was what you chose if you couldn't get into orthopedic surgery. I think now more so people are actively choosing physiatry, both because it's pretty different than orthopedic surgery as well too. I think the biggest challenge that we have in physiatry is, and I think that it goes a long way when we start, I have plenty of friends in anesthesia and neurology and psychiatry, mostly from my intern year. I got to know them really well during my intern year, and I think that's a huge benefit for doing an intern year at the same institution that you do your advanced program. But I think that the biggest thing is talking to other specialties and kind of showing them, what we as physiatrists can do and can offer. Because at least when I was an intern in internal medicine, if there was a physiatrist, for example, that said, "Oh yeah, I can take care of your patient in this rehabilitation at a subacute nursing facility or at an inpatient rehabilitation center," that really helps with their discharge planning. And I think a lot of residents and physicians are relieved that their patients are going to be in good hands after their hospitalization, because they don't think that patient can necessarily go home right away, but could use a little bit of extra support that we as physiatrists can offer. I think that between, I don't know if it's like the new and the old generation, but there's certainly a lot of, camaraderie and especially in physiatry, some of our programs actually are housed within specific departments. Like over at Stanford, they're housed within the Department of Orthopedics. I think at WashU, they're housed within the Department of Neurology. So some PM&R fields are housed within other specialties, but at Vanderbilt, for example, we have our own kind of department. And I think that, that has benefits and challenges. And one of the big things is just getting other specialties to know what we do and what we can offer, and this new way of thinking that we have.
Thea Swenson, what a great talk this has been tonight. Gil and I both, as I've mentioned, work in Parkland ER with the residents, including the off-service resident rotators that come through, and we have second-year PM&R residents that come through, and they are the most wonderful, great work ethic, hardworking, nice people, and you clearly are one of those folks. So what a terrific talk. Let's have everybody. Theo, there were 700 people hanging on every one of your words tonight, and I want every one of them to say thank you on the chat. So just look at the chat and you'll see the hundreds of people expressing their gratitude. Theo, probably roughly around 5,000 students will watch your talk over the next couple weeks. Each one of them in their career will see 100,000 patient lives. 5,000 times 100,000 is 500 million lives that you've touched through your wonderful words tonight. So we are just so very deeply grateful. You've made a terrific talk for us, and the students sharing this with us tonight, I know, have been very much affected by your wonderful words. In wrapping up now, Dr. Salazar, I believe you've got a message for us, do you not?
Can I say something real quick? Sorry.
Please.
Dr. Swenson, thank you so much. You put on a wonderful presentation, and I think you just made 600 pre-med students want to go into PM&R. So thank you so much.
Thank
We
you for
appreciate it. Yeah, so I just have a few announcements if you want to jump off. I know you said you had to go around 8:15, so I don't want to take up any more of your time. But thank you so much. We really appreciate you being on.
you. Probably. And do you need me to unshare my screen?
Yeah. Thank you so much.
Let's see if I can do that.
Perfect. Cool. Okay. And then, so Dr. Salazar is going to say a few things about his program.
Hey, what's up, everybody? Good evening. Let me jump back on here. Okie doke. First of all, thank you to many of you who reached out. Last week was really tough with my dad. You never think it's going to happen to you, and And when it does, it can be devastating, scary all at the same time, and definitely couldn't have done it without all of your love. I really appreciate it. I fell behind a little bit in leading the group, and so I'm a little bit behind on things, but I'm catching up slowly. So I started by making sure I did good to you by putting up my Christmas tree, which I promised in my office. That's what I really, really wanted. So I'm really happy about that. A couple of big items for you. Tomorrow evening, 500 of you were chosen at random to attend the pilot session for the VCOP program. It was random, and so some of you are not going to be able to watch it live. However, we're going to put it as a recording for you to watch it. It's a chance for us to test the system, take a look, make a fool out of ourselves, and kind of find out what works and what doesn't. So once we get that rocking and rolling, we'll be able to provide the first session, probably the first of the year. Okay. I would like to formally announce that our learning management system, which you'll be able to watch the live and recorded sessions, is going to be through Career Cert. Don't go register. Don't go put your name on it. Just wait for us to give you instructions. But they are a phenomenal education platform that are going to be hosting our program. So that's exciting. The price for the entire 6-month program, roughly on average 2 sessions a month, is going to be $29.99. So I did good in keeping it under $30 as I promised. And we are continuing to work on the website. I need permission from UT Southwestern. I want it at UT Southwestern. It's a lot more painful to do it through UT Southwestern, but I want it to be there. So hang tight, and we'll be releasing the registration and payment, all that stuff. So hang tight. Really, really excited about the program. And to those of you who were chosen to watch the pilot live tomorrow, I'll be seeing you there. Thank you.
Thank you so much, Dr. Salazar. Okay, so we're going to talk about QuestSpace a little bit because I know we have been having some major issues. So QuestSpace is down, and I realize many of you did not take session 28 because of this. And so I just want to let everybody know that we will be extending the deadline. We don't know when the new deadline will be because QuestSpace still isn't up, and we don't know when it's going to come back up. But as soon as it comes back up, we will be sure to announce the new deadline. And we will post updates on our Instagram and on our website. And then for tonight's session, again, QuestSpace is down, so you still will not be able to access this session either. But as soon as QuestSpace comes up, we will make sure to let everybody know on our Instagram and on our website, and we will get y'all rocking and rolling on that. So this is tonight's quiz information. QuestSpace is down, so you cannot access this quiz yet, but this is just for whenever it opens. So I hope that clears up any questions. Dr. Fowler, do you want to say anything or close it out, or are we good?
Well, it's just so good to have you all back with us again for this, the 29th session. On the admissions committee, for those of you who are thinking about medical school, we look to see that students have had 50, 60, 70 hours, something like that, of shadowing time. We are now at about 50 hours or a tad more. So if you watch all of our programs, you will have gotten those shadowing hours. So we're going to keep making this available. We've got at least another 6 months planned. So that'll take us up to something approaching 100 hours of shadowing time. And if you keep coming back, we're going to keep doing this. It's so good to have you. The team works very hard the virtual shadowing team works very hard to put this together. And with the new addition, the virtual observation program, we think that we can really be able to supply the needs for the students who are seeking a medical career. So on behalf of you and the 35,000 plus people who have joined us on the website, we just want to say thank you. We'll be here next week. A very exciting session with Dr. Courtney. Mark Courtney is vice chair of our emergency medicine department at UT Southwestern, and he's going to be talking about something very important, which is the issue of clinician and physician burnout and what it really means in a practical area. So tune in, come join us next week, and tell your friends to join us as well. Thank you so much for being here. And on behalf of the whole virtual shadowing team, we wish you a great evening and a good night. Thank you.
Thanks, everyone. Thank you so much, Dr. Swenson.